Well, I asked, and Professor Labridunaki kindly gave me the approval and the consent, so I will quickly address why, when, and how I use androgens in women. This was a short discussion that I presented 2 weeks ago at the first International Congress of the Androgen Society in Lisbon, and I was asked, there was a 90% US-based and 90% men-based, but they asked me to give this, so it is really 10 minutes, but I hope it will open a window on the importance of researching certainly more on this area in women. So, why are androgens so important for women's health and sexuality in the lifespan after puberty? You will see again a few slides, but we'll stress the point. Everybody agrees that testosterone is the king in men, but it's also a king, or better, a pre-queen in women. Remember this, because this is an area, as I said, neglected, the level of testosterone in the physiologic cycle, and these are data from Sperov, accredited endocrinologist in the world, so that we must remember this, that is the reduction with age, not with the menopause, with age of the HEA from 80% produced by the adrenals, 20% by the ovary. Remember this, that the overall testosterone, androstenedione, the HEA are far more representing the women's body than estradiol. They go down with age, but if we perform ovariectomy, but also, as I said, I am an oncologist, in women treated with chemotherapy and or pelvic radiotherapy or total body radiotherapy, the Leydig cells of the ovary are destroyed. So yes, the ovary is on site, but they have very low level of testosterone and the HEA. This is very important because in women as well as in men, testosterone is a prohormone. Say, it is used as a testosterone per se, and very interesting on the brain besides the muscles or the bone. It is aromatized as to estradiol, and this is important for the neurons and glia plasticity, but also it is activated through the 5-alpha reductase to dihydrotestosterone, and this is very important also for the genitals of women, besides the specifically cavernosa body in G-spot. What do androgens do in women's brain? They work on 4 major areas of the brain. First of all, the neurovegetative system, and this is why they boost the sexual response. Second, on the limbic system, and that's why they improve the mood, obviously, in and at physiologic doses. We are not talking about supplementing, otherwise disaster. We are talking about physiologic levels. Third, they go on the cognitive, cholinergic, dopaminergic pathway, and this boosts creativity, association, and memory. And fourth, on the nigrostriatal dopaminergic pathway, and this will improve the machinery of movement and taste and pleasure in movement. Testosterone and the HEA have both organizational and activational effect on the brain. If we want to talk about brain fitness, as I explained to my patient, synergizing exercise plus appropriate replacement of these hormones may go in different areas. First of all, on the synaptic plasticity, say improving the connectivity between neurons. Second, go on cognitive function, as I said, plus sexuality. And third, very important, anti-inflammatory effects on the glia. But very important to reduce the vulnerability to the aging in women, we do have testosterone is an upregulator of what they call the body workers, say myoblast, reducing sarcopenia, osteoblast, reducing the risk of osteopenia, obviously always in synergy with daily physical activity. We cannot ask our hormone to do everything. No, it does its part of work. But this is important because myoblasts, osteoblasts, and fibroblasts have receptor for testosterone and are modulated by testosterone, and this helps to contrast frailty in aging. But also, testosterone is a downregulator of the upregulated immune system, and this will translate into better, say, profile of immunitary behavior, so reduction, hyperactivity in mast cells, microglia, and TREGs. When should androgens be considered? For a tailored prescription in women, considering indication and contraindication in a single woman. we should consider three major indications to refuel the vital energy and longevity in health. First of all, obviously, women's sexual dysfunction when testosterone is proven low. Second, and neglected completely, autoimmune and inflammatory conditions are often associated with low level of testosterone. And third, obviously, menopause with spontaneous, iatrogenic premature, and the aging process. So just remember these three indications. You remember this? Remember this circuit I presented before, because testosterone works in synergy with erythropoietin, and this is another neglected, or say, not enough considered improvement we can offer to our aging patients. Very interesting, this, when should we consider testosterone replacement? When we have low testosterone women, when we do use hormonal contraceptive, in iatrogenic oophorectomy, in premature ovarian failure, age-related decline, plus a cluster of chronic autoimmune diseases. For example, when we use hormonal contraceptives, we know that we do have a reduction in level of testosterone. This is a meta-analysis of Zimmerman, and you see that according to the different type of progestogen, if you have a levonorgestrel pill, you have a reduction from 31 to 55%, but if you go up with the levonorgestrel or even drospirenone, the reduction is even higher. So with different pills, you have a different impact on the testosterone level, free testosterone particularly, in the body. Very important, we do have a significant increase in SHBG, so the blocks testosterone, according to the dose of ethinylestradiol. We are talking about synthetic estrogen in this study, and related to the type of progestins. But I mentioned before that ovarectomy is very dangerous for women's brain, and these are data from ROC, a prospective study looking at the quality. They look at depression, they published different papers, cognitive impairment and Parkinson's disease. There were 813 women with monolateral mastectomy and other 676 with bilateral in the 50s, and then the follow-up of 37 years. What they found, that women who had oophorectomy before the age of 38, they had an odds ratio of 2.89 of cognitive impairment, and even if the oophorectomy was before 45, that is nothing in the gynecological field, even the odds ratio was 1.88. How do I prescribe androgen for a tailored choice? So now, we have this data from the Holland group. They do add the HEA 50 milligram to contraceptive pills. And what did they find? That the HEA 50 milligram was sufficient to provide an add back of testosterone to women under contraception. So they call androgen restored contraception with different outcomes. First of all, stronger genital sensations with the HEA treatment during self-induced erotic fantasies. Improvement also in increased responsiveness of women to sexual initiative of the partner, greater satisfaction with the partner, and greater effects on desire and arousability, that is the mental effect. And this is the last slide I was mentioning this morning. This is a study published from Genazzani, and the co-worker is Massimo Stomati. You see that in blue, you see in the blue bar the physiological level of different hormones, and with different, green is 10 milligram, 25 is red, and yellow is 50 milligram. So you see that all the children hormones increase, the HEA sulfate, androstenedione, testosterone, dihydrotestosterone. Also, estradiol, estrone, progesterone, always within the range, allopregnanolone. But what we mentioned this morning, but with all the three dosages, you have a decrease in cortisol. And this is the most powerful marker of pathologic aging when cortisol goes high. And the evidence that by giving back the reduced, the HEA, according to the body weight, the clinical history, dosage, and so on, you can reduce cortisol and therefore contribute to improve longevity and health. What about testosterone? I was mentioning testosterone vegetal origin. This is the preparation that we have in the pharmacy. We have this kind of dispenser. You can have 4 different doses so that we can really tailor the dose up to 2.8 milligram per day when we use the 4, or 2 if the woman is not ovarectomized. This is to say what? That we may have a lot of improvements, clinical improvements, mood, sense of well-being, vitality, sexual function, cognitive and motor function, plus amelioration of premenstrual syndrome, improved bone mineral density, improvement in autoimmune diseases, an area that really deserve to be explored. I'm not saying that testosterone does all, but it may contribute to modulate, projects of longevity in health. So my point is that when we give back to women topical steroids in the vagina, we may improve the sexual function, certainly, and the relationship. But if we consider androgen restored menopausal hormone therapy, then we may address all the three dimensions. And as my mom used to say, I treated her with patches of testosterone and the HEA. She was very asthmatic, but with this, she managed to breathe, and she called this hormone the hormones of dignity. Why that? Because she said, I wish every woman to age in autonomy, dignity, and grace. So lifestyles, but also very well tailored, androgen restored menopausal hormone therapy. Thank you for your attention and the opportunity.
Are you going to
I'm also
present
addressing the other if you want. Yes, of course.
Are there any questions here?
There are going to be no case presentations.
No, there are, if you want.
Okay.
Irene was so kind to give me the opportunity because we were discussing testosterone, so I said it's important to show the evidence.
Actually, I have 3 papers on perimenopausal use of testosterone in women.
Fantastic. I will look for them and quote you. So, may I have the first case? Voilà. Dysfunctional heavy menstrual bleeding and iron deficient anemia. So if you like also to learn more about the vulvar pain, the lifespan, this is a just published book with Filippo Murina, vulvar pain from childhood and old ages, very practical. Updates on my website, the case. Now, there's a 35 years old lady, married, 2 children, part-time, employed, white. Consultation complaint, polymenorrhea, 22, 24 days, heavy menstrual bleeding with clotting, and worsened in the last year. The comorbidities including worsening premenstrual syndrome with premenstrual depression, worsening fatigue, cramps, poor sleep quality with 2-3 night awakenings, light hot flashes, and tachycardia during periods, difficulty in concentration at work, loss of sexual desire, unwanted increase in body weight, plus 4 kilos in last year, family history, father, hypertension, mother, type 2 diabetes. So do you have any comment on this first slide? What do you think?
First of all, she's not perimenopausal. She's only 35 years of age.
Well, my dear, no. Voila. Personal history. Autoimmune thyroiditis, diagnosed 4 years ago, and celiakia, diagnosed 2 years ago. She's having a premature ovarian insufficiency, autoimmune. That's why I
would say she has prodromal primary ovarian insufficiency because her FSH levels are, in order to make a diagnosis of any kind of ovarian insufficiency, because I have worked since 1996 in primary ovarian insufficiency, we should have two levels of FSH. So we only have one. Of course, FSH 15, it is at least a marked diminished ovarian reserve. However, I would maybe only called a prodromal primary ovarian insufficiency, because this woman actually can get pregnant. And as far as autoimmune thyroiditis is concerned, yes, 1/3 of women with primary ovarian insufficiency, they also have hypothyroidism, most of them of autoimmune origin.
So, of course, this was the first consultation, so I couldn't have the second exam yet. I know very well we have 2 FSH levels above 30 to talk about insufficiency declared, but the key message for the younger colleagues here is that when we have an autoimmune disease, whatever it is, optic neuritis, immune thyroiditis, or celiakia, always think about an impending risk of premature menopause. This is my key message for the beginning of the story, because otherwise we have these poor women having symptoms for a year before someone says, wow, it could be a premature menopause. I work a lot on premature menopause. 17% of my patients are younger than 40. I have even patients around puberty with premature menopause. So probably I have a window in my head, and that's why I'm stressing in all my conferences, think of it when you have an autoimmune disease. This is the first take-home message. Why? I agree 100%. The international definition of premature menopause is to have 2 dosages of FSH above 30, some say 40, at 40 days distance. But this was the first consultation. You say, why? Because many of my patients come from all over Italy. So according to the problem, the report, we send the exams we need. So when they come, I have already, for example, these levels. And she have very serious iron deficient anemia, 8.5 grams of hemoglobin, very low ferritin, very low iron, and this explains, as I show in a moment, a lot of her symptoms. That's why thinking about bleeding anemia is absolutely a bio-univocal thinking, plus obviously doing all the other exams.
I don't know if you agree. I think for this part of the presentation, maybe we should have interaction from the audience in every piece. Irini, I don't know how you would like to go on this. Okay. Can I because
I'm very happy if
I have to, you write celiac. Is it celiac disease diagnosed 2 years ago? You mentioned.
Yes, but as you know very well, diagnosis doesn't mean that she has the problem now. Usually have 8 to 10 years of symptoms before the correct diagnosis of celiakia is made. And we know that when you have a celiakia, you have a cofactor very important in anemia because the absorption of iron and vitamin B from the bowels is significantly reduced.
Yeah, actually, I would like to comment on that because this is a very important topic, this one. Celiac disease, it is very common in Italy. I think it is quite common in Greece as well, although it is underdiagnosed. And
Like
it is
in
also associated with infertility. Sometimes we call it of unknown unexplained infertility, with primary ovarian insufficiency, and with miscarriages. So it is definitely something important, not only from the anemia, but also for, like here, the primary ovarian insufficiency that this patient might have.
Very important comment. This lady fortunately has 2 children, but for all the women that we have now, 35 plus, without children, thinking about celiakia is an important issue because this autoimmune dynamics will impair the quality of the egg, so to say, but also when we have inflammation, we cannot seed. An inflamed uterus, an inflamed pelvis is a less fertile pelvis. So this is another very important issue. But let's go ahead. Why, and this is why I separated the story of the comorbidities to the bleeding problems, because I knew I would have addressed specifically the heavy bleeding in this case. So we must first of all think about the many etiology of heavy menstrual bleeding, anovulation, certainly, defects on the luteal phase, but also the organic etiologies. Systemic, low platelet count, this is more evident since the puberty, defects in coagulations, lifelong heavy menstrual bleeding, but with age, fibroids, polyps, adenomas, hyperplasia, or even frank gynecological neoplasias are certainly in the spectrum of differential diagnosis. Very important, the heavy menstrual bleeding increases pain and dysmenorrhea up to 5 times. So bleeding and dysmenorrhea, another strong association, and long bleeding increases dysmenorrhea by 2.38. So 2 factors to be considered, and we may say that dysmenorrhea is the key symptoms of heavy menstrual bleeding besides anemia. The iron loss in patients with menorrhagia is 5-6 times higher than in women with normal menstruation. We can have different modalities, and we consider that the iron lost per cycle, when it is over 87 milligrams per milliliter, become pathologic. The comorbidities, in Italy we have almost 1,700,000 women anemic, before the menopause and after, and you see the prevalence in different countries. I'm sorry I don't have Greece, but overall we're around 55. The point is that heavy menstrual bleeding lowers the vital energy, like our patient was complaining, reduces the ability to study or to work, reduce concentration, memory, attention, but also damages the self-image and increases pain perception because we have a variability in the gut control of pain. Comorbidities, fatigue, depression, difficulties in concentration, memory, but also loss of sexual drive. Think of anemia, think of iron loss when women complain of low desire before referring them to the psychotherapist. Because sometimes with very easy intervention, you can improve their quality of life. The connection between heavy menstrual bleeding and dysmenorrhea goes to the anemia and the fatigue. John Stevenson this morning made quite a number of very interesting comments. For example, another variable, fatigue when we have a poor insulin control in overweight women. So differential diagnosis again, I don't want to be minimalistic. Anxiety and depression are triggered on one way, genetic. 2, fluctuation of estrogens, but 3rd, low iron level. So again, differential diagnosis, I'm used to tell my patient that any problem, but say, let's talk about depression or premenstrual syndrome, or low desire, or fatigue, is like a river with many, many affluents. I have to recognize each affluent so that I can really give a solution. Iron deficient, highly prevalent, beautiful paper in the New England Journal of Medicine by Comaskella of my very same hospital. How can I diagnose anemia? Test ferritin, first stage. Low ferritin is the first stage. Low transferrin, second stage. Low plasmatic iron, third stage. Iron in the body, where is iron? Iron, 4-6 grams of iron, 2 grams in hemoglobin, in erythroid cells, then in the myoglobin, that's muscles, then macrophages, but very important also in the brain. So if our women say, why do I have such a low level of energy? I say the question the other way. Why iron means energy? Because 60% in the hemoglobin, 13% in the myoglobin, but another 10% in the dopaminergic pathway. This means the energy to live, to do, to act, to explore, to take care of a family, to do a job. But again, don't be minimalistic. Heavy bleeding is one factor, but I must differentiate and check other factors. What the quality of diet? Poor women have a major reason for being low in iron. They don't take meat. Second, food restriction, the self-made diets, vegans, vegetarians, this is the first subset. Second, very important, inadequate intestinal absorption, gastritis, celiac disease, very important and underappreciated etiology of anemia, gluten sensitivity, lactose sensitivity, irritable bowel syndrome. You see, if you go on PubMed, a peak on publication of anemia associated with irritable bowel syndrome, increased losses, certainly, heavy menstrual bleeding, but also the little losses daily. When you brush your teeth and you lose a few milliliter of iron or blood, but at the end of the day, 3 times a day you brush your teeth, at the end of the month, this is a neglected cause of anemia, plus increased need, adolescence, pregnancy naturally, and sport. Iron deficiency, a lot of symptoms. This is the paper supporting the fact that when women are anemic, have a twice the risk of depression, but also worsening of the premenstrual syndrome, as the colleague was mentioning, Sophia, before. Look at the data. When you are low in iron, this is how your ability to concentrate, be focused on your job or your study are reduced. And what's the point? The iron deficiency can produce long-lasting impairments in all the dopaminergic-dependent synaptic plasticity in the hippocampus. A very recent paper showing that even memory is impaired when you are low in iron, and also this contributes to the learning deficits in this age phase. Athletes need more, but I go to the point that women with heavy bleeding, even young women, complain of higher fatigue score and higher menorrhagia severity score. And if we check their ferritin level, 87% are ferritin below 40 nanograms per ml, and almost 30% are ferritin lower than 15, very, very low. So remember, check ferritin, costs nothing, and you have immediately the first stage diagnosis of this. Very important if we want to supplement iron, because we may need it, the fatigue decrease. We may have different treatments, ferric carboxymaltose. This is, again, an overview on different treatment efficacy, iron sucrose, iron isomaltose, or oral iron if the anemia is not that serious. I'd like to stress this, that even the threshold pain is modulated by the iron level, by the level of anemia. Why that? We have the evidence that iron supplementation reduces the vulnerability to pain, and you may say, why does iron have an analgesic effect? Possibly, again, through the gut microbiota and the gut-brain axis, particularly if we had a very specific probiotic, ECN, that has a fantastic, marvelous history. Now it has 100 years since it was discovered. So we have gut-brain symptoms and viscera-driven symptoms. This is this probiotic that I like to share with you because there is a strong evidence on the modulation of the gut threshold of pain. You see, this is the irritable bowel syndrome associated with anemia and worsening the consequences of heavy menstrual bleeding. This is when we have in experimental condition the salmonella, disruption of the tight junction of the bowel, and then when you treat with this ECN, you have an improvement. But this is what I want to go. The anti-inflammatory activity, barrier effect, analgesic activity, again, a synergistic effect addressing, and this is the paper, analgesic lipopeptide produced by this probiotic going to modulate the gut threshold of pain and modulating through the iron the impact of anemia on increased vulnerability of women to pain in general, but also to dysmenorrhea. So you see that putting different pieces of the mosaic, we will have a different impact. We have an issue of money. You know this very well because this means lots of sanitary pads, analgesic, but most important, loss of working days and productivity. We do have very huge studies on direct cost and indirect cost, but also cosmetic. Anemic women all complain of poor quality of hair, and this is also important for their body image, particularly in the transitional age. The medical therapeutic option for heavy menstrual bleeding, that's why I didn't mention them before, not to repeat myself twice, are according to the guidelines and what we see. It could be the anti-inflammatory, the tranexamic acid, progestogen, IUD, or COC with different levels of evidence and of patient satisfaction. The guidelines, I focus on US, Canada, UK, France, and Finland, and you see that they all agree that the medical treatment is the first-line treatment unless contraindicated, and if the patient choice or preserved fertility is not desired. Second, we have the COC, considered first line, US, Canada, second line or third line, UK and France. Progestogens, again, we have differences across countries in the guidelines. The IUD ranks first in all the guidelines. So again, we do have a compendium, so to say, of guidelines, and we may say, first of all, they all agree that medical treatment should become first, except if the woman has different considerations. The hormonal treatment, COC, first line for 3 countries, also Finland, but also IUD ranks first for all the 3. So this to say that obviously the other lecture was focusing on other aspects that are not addressed specifically, for example, with the IUD. The estradiol dienergic is the only approved. We all have this data that I already presented, but just to summarize the fact that according to the individual need and according to the comorbidities, that's why my first lecture was on the comorbidities, we will propose the most, in our knowledge, the best dress to address not only the bleeding, that is certainly the complaints the woman is coming to us, but also the other symptoms, like in the lady I propose. Because we have the responsibility to recognize and treat heavy menstrual bleeding for a number of reasons. Also, for maintain a higher level of energy and quality of life. I commented already the sexuality, but going back to the lady and concluding the case. What she reported was, after 6 months, significant reduction of menstrual bleeding with months of amenorrhea. For for example, for 2-3 months he didn't see any bleeding, and we must inform the patient, and 20% of women treated with this pill, Dianogest and estradiol valerate, do not bleed at all. That is a fortune for these women because they obviously improve their hemoglobin and so on. In the symptoms, in the comorbidities, she reported no more PMS, better mood, light fatigue, but certainly not the one devastated she was complaining. No more cramps, because iron is critical for cramps. And when we are anemic, more cramps. When we have a good level of iron, cramps go away. Much better sleep. She complained of one night awakenings. No more hot flashes. Better concentration. Sexual desire is improving. And I like to mention 2 quotes for this woman. Body weight reduction with diet and daily brisk walking. And she said, but doctor, now I have the energy to walk. Obviously, she was so anemic, she didn't have the energy to make a step. And second, and very important for the Italian, better body image. Everybody tells me I look younger and more beautiful. And this is the social mirror that's so important in endorsing the quality and the strategy of treatment we decided. So I thank you for your attention, and I think I made the comprehensive with the other one.